So I do work for Hope Through Healing Hands. I've been the executive director for about 6 years. It is a organization that was founded and chaired by Senator Bill Frist. He was our former majority leader from the state of Tennessee. He founded it in about 2004 as World of Hope and then changed the name a few years later. And when he was done with politics, and I was in Washington as well, we joined together and launched Hope Through Healing Hands and put some programs with it. Our mission is just to promote improved quality of life for citizens and communities around the world. So our flagship program, as you may know, is our Frisk Global Health Leaders Program. Bethany here is, or Beth is showcased here. She's been a Frisk Global Health Leader for 2 different times, and a number of others as well may have been Frisk Global Health Leaders. We offer this program from anywhere from 3 to 6 months through grants to a variety of different institutions, largely in Tennessee. So, you know, this is medical students, nursing students, public health students, and some pharmacy students. And we've sent these students and residents all around the world to Asia, South America, Africa, and Appalachia. And to date, we've sponsored 22 ETSU students out of the 75 or 78 that we have sponsored through the program. So today I am here to talk about the Faith-Based Coalition for Healthy Mothers and Children Worldwide. This is a new partnership with the Bill and Melinda Gates Foundation. We are excited to partner with them on Melinda's initiative, which is a commitment to really international family planning or healthy timing and spacing of pregnancies for 120 million women around the world. We have partnered with them to really galvanize faith communities across the nation on these issues. So we are here to help promote awareness and advocacy for maternal, newborn, and child health, as well as healthy timing and spacing of pregnancies. Encourage faith leaders to learn more about the successes of healthy timing and spacing of pregnancies, and to galvanize leaders to share their interest with policymakers. To enhance understanding and encourage stronger support for foreign assistance around maternal, newborn, and child health, as well as healthy timing and spacing of pregnancy. So there is this political strategy around this for bipartisan leadership to leverage funding around healthy timing and spacing of pregnancies or international family planning. So for the next slide, I'm going to ask you this. Does anyone know what is the amount of funding that we spend in foreign assistance with our U.S. budget? What percentage of the U.S. budget is spent on foreign assistance? Do you know? Take a guess. 2%. That's a great guess. Anybody else? So Randy may know this, but the Kaiser Family Foundation has pulled this for years, and in 2013, last year, they pulled it again. It's usually around 25%. Last year, they pulled it about 28%. So 50% of Americans, the average American, thinks we spend about 28% on foreign assistance, when in fact we do not. We spend actually less than 1%. It's actually about 2/3 of 1%. I mean, it's that tiny little, tiny little sliver here, this little blue. So what I'm talking about today is not just 2/3 of 1%, but it's actually the accounts of maternal, newborn, and child health and international family planning, which is even smaller amounts of that. And this is the U.S. Global Health budget, just to look at what current funding levels are around maternal child health, around $705 million. And this is family planning and reproductive health, around $524 million. And this has remained stagnant for about the last 5 years. And here's the others: HIV/AIDS, Global Fund, PEPFAR, neglected tropical disease, nutrition, tiny amount, $115 million. So just to kind of set the stage, what we're talking about in terms of political advocacy. So going back to the issues themselves, why do we think these issues are important? You know, why are we not doing clean water, or why are we not doing HIV/AIDS? Well, 1 out of 39 women in Africa will die in childbirth. Those are the current statistics. Some of the lowest, that's one of the greatest statistics. South Asia as well has a high level of death from childbirth. Every year, about 287,000 women will die related to pregnancy or childbirth-related causes. That number has actually gone lower over the last few years, which is the good news, but we're still here, needing to decrease that number. About 99% of those are in developing nations. 80% of all maternal deaths are preventable through timely prenatal and postnatal care, skilled birth attendants during delivery, and the availability of emergency care. There's a great program, Saving Mothers, Giving Life, that I don't know if you guys have followed that in Uganda and Zambia, that has really illustrated this prevention, combating maternal mortality. And then every year, about 1 million children are left motherless, and children who have lost their mothers are up to 10 times more likely to die prematurely than those who have not lost their mothers. So, we're really dealing with infant mortality, maternal mortality issues. So what are we talking about when we talk about healthy timing and spacing of pregnancies? So the first thing is, what is healthy timing of pregnancies? Well, it would be safer if the woman would choose to have the pregnancy between the ages of 18 and 34. So in many developing nations, and we'll talk about Ethiopia here in just a minute, child marriage is a common practice. 50% of all women in Ethiopia are married before the age of 16. We met a girl who was married at the age of 10, for instance. So we're talking about delaying motherhood as a critical piece of saving the lives of the mothers surviving childbirth. Young teenage women are 10 to 14 times more likely to die in pregnancy than those aged between 20 and 24. On the other side of that, older women with 5 or more children are 1 to 3 times more likely to die than a woman who's only had 2 to 3 children. So prevention of pregnancy before 18, delaying motherhood, and after 34, after 35. And then healthy spacing of pregnancies, really trying to space those pregnancies every 3 years. So you have the child, wait 2 years, and then get pregnant again. And in doing so, you actually double the life expectancy of the child. The child is twice as likely to survive infancy, and they are healthier. So again, combating infant mortality here. The time between pregnancies also allows the mother to provide benefits of breastfeeding, physical, mental, social, emotional support during the 3-year period before they have that next child. So Senator Frist and I recently, within the last 3 weeks, wrote an opinion piece with Time magazine called Contraception is a Pro-Life Cause in Developing Nations, and really illustrated the importance, perhaps hidden engine, if you will, of family planning or healthy timing and spacing of pregnancies as a critical component of maternal and child health. More than 222 million women around the world have said that they, in fact, don't have access to contraception, but they do want access. They want to avoid pregnancies. And the Bill and Melinda Gates Foundation, along with other partners with FP 2020, are seeking to meet this need for 120 million of those women over the next decade. So when we talk about healthy timing and spacing of pregnancies, we are talking about family planning. When we define family planning, since a lot of this is just language, rhetoric, we are talking about enabling women or couples, families to determine the number and timing of pregnancies that they want, including a voluntary use of methods for preventing pregnancy, not including abortion. So we are, in fact, talking about a pro-life cause here that are harmonious with their values and religious beliefs. And in partnership with the Bill and Melinda Gates Foundation, I would like to say that they actually do not support or fund abortion either. And then if you want to talk about the political level, the Helms Amendment prohibits the U.S. government for providing foreign assistance funding for planning or healthy timing and spacing of pregnancies. So why, again, healthy timing and spacing of pregnancies? I have worked in the space of HIV/AIDS in Africa, extreme poverty, education, worked around clean water. Why this? Why now? Well, the senator and I have worked at the forefront of maternal and newborn and child health for the last 5 years with Save the Children, and we do think that this may be the next most critical global health issue. It touches on so many other Millennium Development Goals, and I don't know if you guys are familiar with all the Millennium Development Goals, but if you look at maternal and child health as kind of an axis of global health issues, it can combat extreme poverty. It can delay motherhood, allowing that girl to stay in school. It can improve child health. It improves maternal health. It contributes to gender equality. It combats infectious disease when you're talking about prevention of mother to child, transmission of HIV. So for that reason, we really do think it may be the next most critical issue to address in the global health spectrum. In terms of statistics, it contributes to the reduction of poverty and hunger. It would avert 32% of all maternal deaths and nearly 10% of childhood deaths if it was available to all who want it. And that's related back to the 222 million figure I showed a moment ago. Another life-saving issue is the prevention of mother to child of AIDS. It can be preventing unintended pregnancies among women already living with HIV. Reduction of abortions is another reason. Every year there are 210 million pregnancies, and of those, it's estimated that 80 million do not want to be pregnant, about 37%. Over half of these pregnancies, 42 million, or 1 out of 5, end with an induced abortion. Abortion-related injuries account for 13% of maternal deaths worldwide. So in looking at this, actually, I will say this, that 37% of developing nations are unintended pregnancies. But does anyone know what the statistic is for the state of Tennessee for unintended pregnancies? It is, it's 50. So yes, so there could be much discussion here between domestic and international issues. So, and then lastly, effective contraceptive programs, healthy timing and spacing of pregnancy programs could avert 51 million abortions in the next decade. Education. So healthy timing and spacing of pregnancy results in women that are able to pursue education. Obviously, they can continue their secondary school, perhaps move on to tertiary, a college or university, which of course leads to financial stability for her family, for her community, which is all the good news. But if she's already had a couple of children, it may allow those children to continue in school, so she's not having that 4th or 5th child, and then child number 1 or 2 has to drop out of school. So it's affecting both generations for education there. And women who are empowered to make choices about childbearing are more likely to get more education, more job experience, and contribute to the economic health of their families and communities. And of course, implicit in this is women's empowerment and gender equality issues as well. And then finally, economics. Research has shown that personal savings and investments, of course, increase when working parents have a number of dependents that is more manageable given their means. And I want to offer Ethiopia as kind of a model country for this in the next few slides. And we'll see a direct correlation between contraception prevalence, the rise of contraception prevalence there, and the GDP per capita. So about 2 months ago now, I went to Ethiopia with the Center for Strategic and International Studies program. I don't know if you guys are familiar with that think tank in Washington. It's a bipartisan think tank. And we went to Ethiopia to look at it as somewhat a poster child of a developing nation that has done really great work in providing access to family planning for women across the nation. Their contraception prevalence has doubled in 5 years from 2005 to 2010 from about 15 to 30%, which is really high. The highest unmet need is still among those young married women between 15 and 19. They're not getting access, and that represents about a quarter of the women in the population. Why are they not getting access? In talking with a host of women and leaders in the community, a lot of times it includes the gatekeepers. The husband doesn't want the woman to have access because he wants her to be able to become pregnant. Mother-in-law may not want the wife to have access because she wants grandchildren. The religious leaders may not be supportive of contraception and preventing pregnancies. And there's cultural leaders that may not agree to this either. So there's a number of barriers here we're talking about. And of course, as you all know, each country is different. Each province within each country is different. So there's just a number of cultural barriers that are not monolithic that women are having to deal with. Their hope, however, is they're finishing their statistical counting right now, but they hope by the end of 2013 the statistics will show that 40% of women now have access and are currently using family planning in Ethiopia. So how did they do it? How did they double their contraception prevalence? How can we model this for other developing nations? Well, they have this health extension worker program, and I don't know if any of you are familiar with this or have been to Ethiopia or spent time there, but it's really unrolled in the last decade. It's a tiered system managed by the government and employs about 38,000 health extension workers, which are 99% women. They have about 10 months of training. They're fresh out of high school, most of them, and they're going back to the communities in which they were raised. There's 2 of them at each health post. So they're going into these communities and they're going to these health posts. The health posts don't have electricity. They don't have running water. They don't have much of anything. But what they do have is access to pharmaceuticals, and these trained health workers, they have a bed, and they have just some basic primary care materials and tools to deliver care in that community to about 5,000 people. They also, one usually stays in the health post and one is mobile out in the community, figuring out who missed their last injectable for contraception, or what child is sick and needs to come into the health post, that kind of thing. So they work in tandem. This is Marette, who we met, and Marette was a child bride. She married at 10 and had a child about 4 years later, I think, and is now a huge advocate for family planning in Ethiopia. Speak to us. After the health post, it's a structured system. There are health centers, which have a little bit higher level of skill and care for patients. They manage, these health centers have usually a physician or high-level nurses that help manage 5 different health posts. So they're providing services for actually 25,000 people in the area or region. And they offer their antiretroviral therapy services, TB services, family planning services, youth-friendly services, and antenatal care including delivery. So that's where you go to have your babies. You want to go to the health center. You don't want to go to the health post. They have electricity. They have running water. They have internet, that kind of thing. Since 2009, we were up in the Tigray region, which is up in the northern province. This health center right here that you're looking at estimates that 8% of women chose to deliver her baby there, but by 2013, they claim that 95% were seeking services for delivery, which is a huge behavioral change, everything changed, but it's also really saving the lives of these women. I mean, this is really the first step in combating maternal mortality. So going back to contraception, these are photos taken back in the health post, okay, for the 5,000. They had condoms there, they had oral contraception right here, injectables, they use Depo-Provera. They can offer implants. So the health post worker with her little training can still offer the injectable. She can also offer the implant. Now she can't take it out, The patient actually has to go to the health center to have that done, but she can inject the implant. The health center does not offer IUDs. You would have to get that actually the health post does not offer it, the health center does. So again, that's a higher skilled practice. But these are what are available. And by and large, women are choosing injectables, probably because it is invisible, and husband, mother-in-law, others don't know she's taking it. There's a new contraceptive technology they're using there and rolling out called Jadel. It's a new implant, but it can provide coverage for up to 5 years instead of 3 years. So women were just learning about this and trying this out. So it was at a low usage, but they spoke at length about it to us at the health center. And then here's just another picture of family planning services at the health center, and you can see the depot and the pills, the gel. So the women can come in and they can choose whatever they want. You know, they're coming in to get their whatever services for their children or their TB services, and then they are educated on what their options are and what they have available. And I will say there were PEPFAR posters and USAID posters. I mean, it was clear that U.S. government funding was providing this and other services at these health centers and health posts. So thinking about from family to nation, with the advent of increased access and delivery of contraceptive commodities and services in Ethiopia, again, the contraceptive prevalence had doubled from 14 to 50%, or 14 to 30. It doubled, so it's 51%, right? And then the GDP per capita as well doubled. So you can see here, they have made the correlation here, or they claim the correlation between this contraception prevalence and the GDP per capita. I will note also that between 2005 and 2012, Ethiopia saw a 30% decrease in maternal mortality, probably also because of these health centers who are offering and promoting, delivery in the health center, not at home. And then a 15 or 16% decrease in total fertility. When we were there, we had the privilege of meeting the First Lady, which was the wife of the Prime Minister. Her name was First Lady Roma Tesfaye. And we spoke with her for about an hour, and she really wanted to talk about women's empowerment, her country, contraception prevalence. She was really excited about the increase of women and girls' attendance in schools. In primary schools, they had increased, in secondary schools, and they had actually enrolled 51 new universities over the last 5 to 10 years, and these girls were attending college and university now. She linked it all back to contraception prevalence because they were able to delay motherhood and could go to school. So her quote to us was, when a woman contributes to her family, she contributes to her nation. And in saying that, she is meaning that when a woman is able to provide economic stability for her family, she's in fact providing stability for her community and her society and her nation. And when it links to really talk about gender equality and the excitement of empowering women in Ethiopia. So what can you do? So back to the faith-based Coalition for Healthy Mothers and Children, and as it relates to all of this work, you could learn more, educate yourself on this. We have resources on our website, hopethroughhealinghands.org. Bill and Melinda Gates Foundation has resources, and I'm sure Randy and others can offer resources, your professors. Choose to write a paper on this topic. Consider placement of the paper for publishing. Even if you rewrote the paper for an opinion piece for a newspaper or a journal, whether it be local or regional, but thinking about publishing. Our Twitter handle is @HTHH Global. We would encourage you to follow that. We offer 2 or 3 daily updates on Twitter that are largely informational and educational and relate back to maternal and child health. Share with your family, friends, and community. We're about to head into summer here, and you're going to be going to barbecues and this kind of thing. And really just talking with your family and friends about these issues is one of the best ways to start promoting awareness for these critical global health issues that might otherwise no one thinks about, nobody talks about. And then lastly, call your congressional representatives, your senators, your representatives, and tell them you care about maternal, newborn, and child health, that you care about healthy timing, spacing of pregnancies. I've met with Senator Corker's office and Senator Alexander's office and others' office, and definitely Senators Corker and Alexander are supportive of these issues, but in a landlocked state like Tennessee, a lot of times their constituents aren't thinking global health. They're thinking Tennessee. We do need so much here. Or they're thinking US, domestic issues. So to call them and let them know that you support them gives them so much encouragement to continue their strong leadership around global health. And again, this is all relating back to that foreign assistance on less than 2/3 of 1%, which does so much good around the world. And then finally, you can learn more at hopethroughhealinghands.org. So I'm happy to open it to any questions that you guys might have.
What's the cost associated with the contraception? Is it free to all women, or is there a small cost for visiting a health post or health center?
That's a good question. It was different in different areas for different kinds of health centers, but those that were related to the Health Extension Worker Program were free. But if you went to a different, they called them kind of like a Blue Star Center, there was a scaled pricing. So it just depended in Ethiopia where you went to obtain your contraception. Yes?
So with the health post, I know that there was a lot of promotion for the actual health centers for delivery. So was transportation an issue as well, getting those women to the actual health centers, or worried about them from the health posts?
Yes. So the reason they went with the health post was that hopefully the woman within an hour could walk to the health post and not actually, waste her entire day spending it going to the health center or with the child, You're not walking 10 miles, they're walking like 1. But that being said, when the woman was pregnant, they would carry them on like cots or, stretchers basically. And they would designate a couple of men in the community, and they would bring them home. So that was the ambulance for these women in that case. Yes?
You spoke a lot about the barriers between stakeholders, being husbands or community leaders. How are you trying to bridge the gap specifically within the religious sect in making contraceptive more available?
So there was actually some great programs going on that were supported by the Population Council and others. And they had created what's called a development Bible there. So Ethiopia has about 33% are Ethiopian Orthodox, and then another about 25 are Muslim, and then the remainder of that are Protestant Catholic, really. So you're talking about a really conservative country. But for the Ethiopian Orthodox, it is a very hierarchical system. They had created this development Bible that could be distributed throughout the country to Ethiopian Orthodox priests. And it was almost like a daily devotional. And it focused on a different global health issue, development issue, and then correlated that with a biblical scripture every day that could be used in the church or for private devotion. But in that way was an educational tool for priests, as well as an awareness raiser for the communities. And that was in their spoken language as well. So So that was one method. We did speak to a couple of priests who modeled the family planning and would bring their wife to the health post publicly to show that they were supportive of contraceptives. And every region was different. Like the Tigray region was great, and other regions were a little bit more conservative in that area. So, yes.
The countries chosen.
That's a good question, but the funding is going to run through USAID, and then different programs are going to receive that said funding, and that will be distributed to a variety of different developing nations. So it's a complicated
I
process.
didn't know if the faith, if that had anything.
Well, we aren't actually doing any distribution of funding, and we are not a service provider in this instance. We are actually just speaking to Americans, folks like you guys, influential leaders, faith-based leaders, academic leaders, artists, actors, a variety of cultural leaders, to just promote awareness and promote advocacy for these issues. So really just educating the U.S. here about these issues. Yes?
How can a country that is now already being catered to participate? A country that you don't have now, like you have Ethiopia, how can another country, like my country, Liberia?
Well, and Liberia may already receive funding for family planning. They may have a line item for that. I don't actually have a list of the developing nations who receive funding directly out of that tiny slice. I could go back to the slide. That's allocated for family planning and reproductive health, but we could provide that.
Some of the funding will go from the U.S. to the host country government. It also goes to non-governmental organizations that are in that country. And basically, at least for AID, they almost never fund an NGO that isn't already in country. So one way would be to look at what NGOs you have in country that could then apply for that type of funding. Everyone hears the term faith-based,
Right.
and sees it through their own eyes.
Right.
How do you envision bringing together faiths whose belief systems may not overlap on this? I mean, some
Right.
will accept contraceptives, some won't.
Right.
Some are okay with termination, some are not. How do you envision bringing them together?
So that's a great question. When we talk about faith-based organizations here, we'll largely talk about Christian organizations, Christian leaders, I should say, and other cultural leaders. For instance, though, Catholics don't support contraception as a hierarchy, right? So we have partnered with Catholic Relief Services in Georgetown to really look at natural family planning and fertility awareness. So, that's another critical component of a contraceptive that's available to women in developing nations, to really learn about their bodies, the cycle beads. Beth, I don't know if you did all the cycle beads, but a lot of the First Global Health leaders will be in maternal centers where they'll talk about this. So thinking about Catholics with the natural family planning, and then others support some contraception and not other contraception, but really finding where we can agree and how can we move forward together, because it is such critical importance to combat maternal mortality and infant mortality. So it's a dialogue and process, frankly, but I'm optimistic about that dialogue. Yes?
I can see opportunities for similar programming here in Appalachia among subsets of our population of women who might not be empowered, not adopt contraceptive practices at a very high prevalence rate. So how would you draw a parallel between this type of programming and a replicable program here in Northeast Tennessee, South?
Right. And that's an excellent question. In fact, the Nashville Scene just asked that question in an article this past weekend. I don't know if anyone saw it, if you may not read that, but It's a great question. You know, in talking about healthy timing and spacing of pregnancies, we have been very deliberate in the creation of language around this. I did use family planning today. Often I may never use that. I may choose not to use the words family planning depending on the audience that I'm with, because I don't have to, because it means the same thing for us. And we're not talking about abortion. But I say all that to say the rhetoric is an issue for the dialogue, and we all need to, as we think about pulling together a variety of leaders, we need to come together on what is the choice of language and what do we mean by it, and really trying to take away the emotive elements that have been so attached to issues around family planning for decades. So really kind of rethinking that. So I say all that to say sometimes it's easier to talk about this in a totally global health context when we're talking about global health funding and foreign assistance spending, and we're not necessarily dealing with the domestic issues here. But in my experience 12 years ago, really doing the exact same work around HIV/AIDS in Africa, the climate here to talk about HIV/AIDS was just hostile. It was a hostile environment, even among faith leaders. We would go to faith leaders and say, people are dying, they didn't care, you know, and there were all kinds of reasons why. It's a different climate today, and I think it's mirrored that, or things have changed in the US because of some of those awareness activities done to think about AIDS as a pandemic rather than a domestic issue. And my hope is that something similar might happen over the next decade with family planning.
We see really ugly dialogue around criminalizing women who become dependent on prescription painkillers, for example, or give birth to a baby who's also chemically dependent. I think the rhetoric around that phenomenon is so divisive and so ugly. You know, people spouting off things like, put them in jail, they deserve this. Could they, when, of course, they're being legally, majority of them are being legally prescribed painkillers. But contraception and primary prevention could play such an important piece in solving that problem. But especially from a faith-based approach, the term family planning comes with some really negative service,
right. Right. No, that's true.
I mean, around here,
No.
it does, for sure.
No, it does.
We were talking earlier both about the importance of how you select words, but also how important it is to debundle issues from each other. You know, we have to, because right now someone will say, I am this political ideology or I'm that political ideology, therefore I believe A, B, C, D, E, F, G. In fact, those things don't logically follow. And I think, you know, what starts to happen in the drug abuse world, you start lumping strong enforcement together, you know, and then anyway, that's just an issue of trying to help people debundle things, and language is a good way to start that, but it doesn't get you all the way.
Such an important topic. Thank you for coming.
Oh, thank you. Oh, thank you.